Good afternoon and welcome to United TV and welcome to Bariatric Friday. My name is Kamal Arkan. Today we are revisiting one of the most and hottest important topic in fighting obesity, and this is weight loss drugs and bariatric surgery. Now, we have covered this topic recently from two different surgeons, and today we are going to have Dr. Rahul Singh from CHRIAS. He's going to join me. Dr. Singh is one of the physicians deeply committed to holistic, patient-centered obesity care. With so much buzz around the medication like Wegovy and Zepbound, we will explore how bariatric surgery fits into a broader metabolic treatment strategy and why surgery is still a critical tool, especially for women dealing with long-term hormonal and metabolic challenges. So we are going to start our discussions, and this is our first time with Dr. Singh, although you have been with us since 2014. How are you doing, Dr. Singh?
I'm doing very well. Kamal, thank you for having me here.
Absolutely. Well, thank you for being with us. So I did mention in the prior session at the end of it, although on the Bariatric Friday, this is our first time, but you do webinars for CHRIAS. Those are second and fourth Tuesday of every month. And I know you do at least one of them every month.
Yes.
This is where we have more kind of structural, almost like a training like presentations for our patients. And so it's not like you are new to these. So, and thank you again for being with us. Now, we covered the bariatric surgery. One of the reasons for the session is to make sure that our patients get the support that they need. So that's why we kind of divide these different topics into like 12, 13, almost 14 in some cases sessions. And it's easier for our patients to go through and then understand what they need to do. And now we have playlists on our YouTube for each topic because we cover them so many times. And I believe this weight loss drugs is going to be another one that many people are going to watch different sessions that we have done with different providers. And the reason is because there's a huge marketing out there. There's a big promotion. Even on social media, you go in, you see Wegovy, the Zepbound, and other medications. Although bariatric surgery is the one of the most efficient tool to fight morbid obesity, almost 60 to 80% of the excess weight being taken care of in the first 6 to 8 months. It's still unmatched by any medication. However, the medication reality is out there, and I would like to ask you, why is bariatric surgery still considered the gold standards for treating morbid obesity?
Well, that's a wonderful question, and I think there are several reasons, in fact, why bariatric surgery is considered the gold standard. For one, all procedures that we perform, every last bariatric surgery that we perform, these were designed specifically for helping patients lose weight. Whereas with the medicines, weight loss was not necessarily the goal of the medicine, but mostly just the side effect. Every medicine that we have, weight loss has always been its side effect, while the goal of that medicine was to treat something else. You know, you can talk about phentermine, which is a medicine which is very similar to medicines used for treating ADHD. So a side effect was noted, okay, it suppresses appetite, so let's use it for that purpose. And then similarly, you know, the latest medicines, GLP-1s, weight loss was a side effect of these medicines while patients were being treated for diabetes. Sleeve gastrectomy, on the other hand, or gastric bypass, duodenal switch, all of these were designed from ground up to help the patients lose as much weight as they could and be very successful with it. Now, these tools, these procedures, these surgeries, these are lifelong tools. This is not something that once you stop using it, like you would use the medicine, this is a tool which would be there forever. So it's always available for the patients to use, and therefore patients are more likely to be successful 5 years, 10 years, 15 years, 20 years down the line when compared to medicines. And we are not just talking about how much weight you might lose. What we are talking about is the long-term effectiveness of a medical tool that we have. Medications are also tools, but the problem is that with the medications, in fact, there's a study that came out just a couple of months ago, which talks about how many people actually end up staying on the medicines beyond 1 year. So by 1 year, 50% of patients are off the medicine, usually because of the side effects of the medicine. By 2 years, about 72% of patients are no longer on the medicines. And that's again because of either non coverage or a lack of availability, but most likely because the patients are having side effects of it. Surgery, patients do great. They lose a lot of weight right off the bat. They're able to get their goals in place, and in the long term, they're successful. And that's why it's a gold standard. If you look at any article in the news or you look at studies, they always compare any new option we have for weight loss with the gold standard, which is surgery. And that's why, because it's a long term, it's a tool which provides long term success. It's a tool which provides more weight loss than other options, and is therefore considered the gold standard.
So you mentioned the indefinite part of it, and as you said, GLPs are requiring like nonstop. It's not curing the problem. It's just dealing with the symptoms and maybe help us to control it to a point, but it's not permanent. So you have to be on it long term. So, and it's also costly. It's averaging $1,500 a month. And well, if they have a really good insurance coverage, it may be okay. But even those are going to become a problem, I believe, within a year or two, because now all of a sudden these numbers, the medication part of the insurance premiums are actually going up, and I believe insurance companies are going to take some action on those. Now, not to mention with the side effects, nausea, vomiting, muscle loss, and possible gallbladder issues. So there's also some weight regain, and I have our internal study, and I'm going to talk to you about that at some point today. So what are the limitations of the weight loss drugs like Wegovy and Zepbound?
Well, so there are a few. Um, well, number one, it's not effective for everybody, for every patient. You know, we're all different. It's not like one shoe fits everybody, right? So these are two popular medicines. They've been marketed very well, but the results, they are variable from patient to patient. So that's one big limitation, is that the weight loss is very unpredictable with these medications. Secondly, the price. I mean, we cannot shy away from that. 1 year of treatment with a weight loss medicine such as Wegovy or Zepbound is almost the same cost as performing a weight loss surgery and providing treatment for a whole year. And now, if somebody is going to be on that medicine for life, that's like a weight loss surgery, the cost of a weight
Right.
loss surgery every year. So that's another limitation. Availability of the medicine. That's a big problem. So, you know, we've been using weight loss medicines as a tool along with surgery for many of our patients to help them be successful. But the problem has been lack of availability of these medicines in whichever pharmacy that the patients would like to use. And then of course, you know, approval by their insurance company. So those are some, you know, common things that we hear from patients.
So we have 134 patients. I was able to have a data validation with actually two of our resources who helped me with this project. I don't know if we can call this like a research, or maybe it's some derivative of research, what we did, but it's a study, perhaps it's a better term to use. So out of 134 patients, we look at, we measure patients only with BMI higher than 39. So in 6 months, the average weight loss was 2.4%, I believe. So now there are some patients on the top with 10 or 12 of them who have like teens, like 10, 12, 13, 14%. And then we have some patients on the bottom side, they gain weight. And then overall, the average, they are at 2.4%, maybe even 2.3. So what I have seen while going through and validating the data is one is they may not be best administered by everyone. Now I'm going to out you a little bit. So your wife actually is one of the weight loss physicians. She's board certified by Medicare, and her approach is different. She's not a surgeon, and I want to make sure that you guys don't have a fight tonight. So we are not going against what she's trying to do. She's a board certified medical weight management primary care.
Yes.
So, and her approach is different. She works with nutritionists when she's working with the patients. Patients do come back on a regular basis, and patients do their lab work. And if we don't see the results, she stops. At least that's what we have seen. But when it's not done by the board certified people, the outcome can be very different. It's not something that you can just put the patient on and forget about them, and then they're going to be okay on their own. In some cases, you need to adjust the dose, right? If you haven't seen the patient, so it's not going to happen. But it was kind of surprising to see. In fact, one of the people who did the final data validation, she's a pre-med at UPenn, and she's like, is this like real? So, and then she has full access to the EMR, and she sees no results. But then, the buzz around these medications is huge. So it was an interesting study for us to see. Now we are about to finish the 12 months of the same group to see if they have a better outcome in 12 months. But when you see a lot of patients actually gaining weight, so you understand that this is not just something you can just put the patient on and forget about it. So this is one of the things that when I was talking to Dr. Irga about this specific issue, in some cases, patients feel like they have this magical pill, and because now they're on it, they can be more free to eat more and without changing anything. And then all of a sudden, like, they gain weight, and this happens. So unfortunately, now we know that surgery always comes with its own stigma because I talk about my family every once in a while. My mom thinks we are cutting everyone's stomach. I'm like, well, not everyone. So this is patients with morbid obesity, and most of our average is about 47, BMI 47. And then we see patients with over 60, we see patients with high 30s, but averaging is about 46, 47. Now, these patients are struggling with life altogether, but the stigma of surgery itself is still out there. What would be your message for those hesitant about taking the next step for surgery?
That's again a great question, Kamal. So, obesity is a major problem in the United States. In fact, by 2030, we expect almost 40% of Americans to suffer from significant obesity, enough that their body mass index is like 35 to 40 or higher. So those are serious health hazard. And the sad truth is that only 1% of the patients that need to see a doctor, need to have surgery for weight loss, actually end up getting surgery. And a lot of that has to do with the hesitation, just because the word surgery attached to bariatric surgery. These surgeries, they are actually a medical treatment meant to treat a very serious medical problem. Mm-hmm. Yes, it does involve modifying a part of one's gastrointestinal tract, whether it is, helping a patient feel satisfied with smaller portions of food, or helping modify the way the food gets digested so they don't absorb as much food, right? Or a combination of this. But it's in effect a medical treatment for a medical problem. What I would tell patients is that, so many of our patients in their 30s and their 40s, 50s, and 60s, when they come back and come back after a few months of surgery, they say, "I wish I'd had this surgery done a year ago. Mm-hmm. I wish I'd had this surgery done 10 years ago when I started to face this problem, but I wish I'd known about it." And then that's what I want to let patients who are a little hesitant about surgery, come talk to us. We will help design the right program for you. What I like to tell my patients is that, just like, Rocky in that boxing ring, right? Fighting somebody. Um, so, has a coach, right?
Hmm.
So, Rocky, so you are Rocky and you're fighting obesity. We as a team, we are your coaches, we are your life coaches, we are there to help you be successful. So, not just, so bariatric surgery is only part of that treatment. The entire treatment is, the nutritionists we have, the psychologists we have, the support mechanisms we have after surgery. If you're struggling with weight loss, we are there to help support that, and we are your coaches for the rest of your life. So we would expect to see you, year after year after you've had surgery. So yes, if you're hesitant, talk to us. Let us know why you're hesitant, and well, and if you're not the right patient for surgery, then we can talk about medications as well. But surgery, it's a great tool. It's a wonderful medical treatment in a sense to treat a medical problem.
And we are utilizing the medication
Yes.
while they're going through the bariatric
Yes.
surgery, as we are getting them ready for the surgery, because we have patients who are over 60, 65. Right now, we have two patients on the list, on the outstanding list with BMI 72. So we are trying to bring them down to 60 if they are men, down to 55. So, and it's not easy when someone is already at BMI 72. You are not going to be able to make one of the reasons they are getting the surgery because they fail to lose weight. So now we are trying to bring them down by 12 BMI points is not the easiest thing. And that's when I know the team approach is extremely important, so that we add more nutrition visits for those patients. We have more checkups with the surgeons. There are more follow-ups with the surgeons, and we are, we keep track of them closely from our care coordination team. So um, it's we are not saying that, well, either this or that. It's just like they're in two different. I think their caliber is different. So the surgery caliber is at a different level. So this is like a 12-cylinder car, and the medication is 2 or 3-cylinder. So it's not going to be able to do the same thing, but definitely it will make some impact. So I think maybe that's kind of like for our patients and other people to understand. This is this is not like, we are not saying that, hey, either you do this or you do that. It's there may be some combination in some cases, because when it's a severe morbid obesity, surgery is the only reliable option for those patients. Now, going back to the long-term outcomes, um, as we mentioned before, the surgery provides a long-term outcome. There's stability, it stays constant, and if certain things are being followed by our patients, the success is inevitable. So it happens, and this is not the case for medication. So how does surgery outperform medication in long-term outcomes, in your opinion?
Um, so, well, for one, absolutely does. Right off the bat, weight loss surgery works for every patient that has the weight loss surgery. Medications don't necessarily work for every patient. Right off the bat, 10%, 15% of patients are actually non-responders. Um, and as I was, uh, as I had referenced to earlier, 70% of patients are off the medicines by 2 years. So surgery is a long-term solution because it's essentially a permanent change in one's ability to consume a certain amount of food or be able to digest a certain amount of food. And because this is a permanent change, the effects of this medical treatment are also permanent, and therefore long lasting. And along with the team approach that we offer, so we are. It's not like taking out an appendix where you had the appendix taken out, now saw the surgeon once or twice and you're
Mhm.
done. This is something. This is, a lot of times, again, I tell my patients, think of us every time you go see your primary care doctor. You go to see them once, you have to come back and see us once a year as well, so that we
Right.
can be part of that treatment plan where we are helping you succeed. You know, and that's why it's a longer term solution. from the longest time, from the time that this surgery, when these surgeries were designed to offer weight loss to patients, they were always designed in a sense that these patients would be following up regularly. Whoever underwent surgery would be following up regularly with their bariatric surgery team. And this has been reinforced, particularly in the last 2.5, 3 decades, where programs were created, bariatric surgery programs to offer lifelong solutions for helping patients lose weight. And that's why, the team approach to weight loss with the weight loss surgery, the permanent nature of the weight loss surgery affords patients long-term, lifelong results.
Absolutely. So, as I'm listening to you, like with these sessions, I always say that I'm the one without the medical license, and usually my guest is the one with the license. So it's a lot of learning, and it's amazing how the session after session, there's still some learning for me in this process. And if that's the case for me, then I can imagine what our patients need and understand, because this is what we do every day. I run case conferences for our team, go through each and every patient one by one, but still there are different things that we are picking up from these sessions. And it's from that point, it's extremely important to hear it from different angle, or different person, or different surgeon. So this does help. I'm learning, so I can tell you that. So earlier I mentioned with some patients we can use this as a combination, but patient who started on medication, they can transition into the surgery for better results. Are there any downside of that?
Okay, this is actually another great topic. So over the last couple of years, in our conferences, in our bariatric surgery national conferences, international conferences even, we are talking about treating obesity more like cancer. Well, and it's important to explain why we use that term, because just like cancer, obesity also shortens one's life expectancy. It causes a lot of other issues which shortens one's life, how much you might expect to live, and increases one's risk of dying from other causes. And in essence, obesity leads to early death, and that's a problem. So what we are talking about in our societies is how to maximize weight loss. So just like cancer gets treated with, what we in medical terms we call this neoadjuvant, or medications that are given before they have the main treatment for cancer, and then adjuvant chemotherapy, which is treatment given after they've had the main treatment, which is usually surgery. So that's the sense, or that's the treatment kind of plan that I have in mind when I'm looking at patients that are suffering from very significant obesity, where they might be very high BMI patients. So start them on some weight loss medicine that they tolerate well, that they're able to work with, help them lose a certain amount of weight. Doesn't have to be a specific number, but has to do more with how they do with that lifestyle change and the medications. Then they have the surgery. We will hold off the medicines at that time and see how they do. Maximize their weight loss with the surgery. Maybe that could be 6 months, 9 months, or a year, and then reintroduce the medicines if that need is there, so that 1.5, 2 years down the line, 5 years down the line, 10 years down the line, they've achieved the maximum potential weight loss. So medicines are a tool in the toolbox. Surgery is like a sledgehammer, right? It's a great, wonderful tool, and then we can tweak things with medications.
Absolutely. So we talk about the financial impact of the medications. When it becomes the long term, what is the financial reality of long term drug use versus surgery?
Oh, there can be so many. So depends how you look at it. One is the financial burden to the nation, in a sense. So it's expected that over the next several years, just the amount of money spent by the country on GLP-1 medications for obesity, it's I think $10 billion. right? It's a big number.
State of Delaware, just for their employees, is about 55 million program year
Right.
2025.
Right. In fact, the country where Wegovy is made in, I'm forgetting the exact country it is, but the biggest portion of their gross domestic product, their GDP,
Coming from
coming from these medications. So there a huge financial burden. On average, $17,000 is the cost per patient per year, um, um, for using this medicine for weight
it's
loss.
Denmark.
Denmark, there you go. So financially, certainly it's a big difference. So if you take a patient who's undergone weight loss surgery, you know, both patients who require weight loss surgery or have weight loss medical treatment require, healthy foods and dietary supplementation. So that is the same between the two. The difference is the amount of direct cost of the treatment, right? So the direct cost of treatment with weight loss surgery, it's less than the cost of 1 year treatment for of this medication, and that's mind blowing, right?
Right.
And now over 10 years, that's $170,000. But the most important part is, let's say at 10 years, both medicine and surgery were equally effective. So fine, spend $170,000. But the problem is that's not the case. This study that I'd referenced a little earlier, it was presented at our conference in June. And what that showed was actually almost exactly, Kamal, what your data is showing. So they looked at, they did a 50,000 patient retrospective chart review, more 51,000 or something, of patients who had surgery or had taken medicines. And they found that by 6 months, exactly close to the figure you'd mentioned, 2 to 3% weight loss. At 1 year, they were at about 6% to 7% weight loss. Whereas surgery, on the other hand, was 25%. So the difference is
it's a different
breathtaking.
caliber.
It's a completely different caliber. Now, when the companies and when the ads and the media talk about weight loss with these medications, they talk about clinically controlled trials where, yes, patients can have 12 to 15% weight loss or 15 to 20% weight loss, depending on what medicine you're choosing. But it still does not come close to this. It does not come even close to surgical weight loss, which can be 30 to 40%, almost twice.
Right. And one of the things that I was just trying to pull for us, I didn't share this one with you, but you probably know this already. One of our cardiologists, Dr. Hosmani, sent me this. U.S. Emergency Department visits attribute by clinicians to GLP-1s 2022-2023 numbers, and how actually the numbers are increasing. A lot of low blood pressure with marked weight loss patients are not being asked to check home blood pressures, and so many other issues. Now, again, we want to be careful. We are all for whatever is going to help the patient, because every patient is going to respond differently. So we are never going to say, because we are actually also prescribing these medications from our practice. We are not saying that you need to pick one or the other. We are just saying that what's the best solution when someone with BMI 54, like when they are at that level. Like if someone is at 31 and they are trying to go down to 28, they can do a lot of things because their physical limitation is less. Their understanding of like when you need that jump start, they can do that with maybe medication and make some changes and then get off the medication and then just get down to 27 BMI. Possible. But the patient with 54, unless there's a big jump start, there is no hope. And 10% weight loss is going to take them from 375 pounds to 350 pounds or 340 pounds. That's not going to get them out of that range. So that's why it's important for us to, let people know that this is not for everyone, and everyone is going to respond differently, and not knowing all the side effects. I mean, one thing that I'm sure other physicians are saying the same thing, but like depending on how much I pay attention. So what you said in the beginning, this drug wasn't made for weight loss. This is a side effect of another problem that they were made for. So we don't know what else is out there that may be coming from these if they are used long term. Maybe short term is different, but if it's a long term, then they can make big changes on person's health, and it may be too late to reverse those issues. And I know that there will be better studies and better tools available. Just like when the bariatric surgery started in the early 2000s, we were doing a lot of gastric band, and then we went to gastric sleeve. Gastric bypass was always there, but it's not the number one choice. Understanding patients should be able to go with less severe, changes, structural changes. And gastric sleeve is a good option for 75-80% of our patient population. But even when they fail, there's, like last week we did talk about the revision surgery. And one of the things, I don't know if you want to talk about it, but even for those patients with gastric bypass, when there's in science, there's no stop, there's no endpoint for learning. And I was explaining one of our employees, she asked me and how this actually works, and apparently there's a history of gastric bypass, and you do overstitch procedures, and that it's a totally different procedure. And I think you're the only one who's doing that in our practice. I don't know if you want to talk about that a little bit.
Yeah, great. So I think, one of the things about gastric bypass is, what to do to help patients who may have regained some of the weight back over time. And a lot of times patients that regain the weight back, they come back and say that, what, doctor, I'm able to eat way more than what I was able to when I had the surgery. So can we do something about it? And so that's where procedures where, you can make the pouch a little smaller, make the opening that connects the pouch, the stomach, to the intestine a little smaller, so that the food just sits in the stomach a little longer. When the food stretches the stomach, the stomach pouch, it makes you feel less hungry, makes you feel more full. So that's where that procedure comes in. It's overstitch is the device. I'm sorry to correct you. The procedure is called a TOR. TOR-E, essentially. Essentially, the translation of that is a procedure done through the mouth into the pouch, and what I can do is make that opening smaller with some stitches, and it stays that way for many months, sometimes up to a year, and can afford patients who are suffering from eating very big portions in a meal after a gastric bypass to be able to eat smaller portions of food, and that can help them lose about 25 to 35 pounds on average, or sometimes even more, depending on how significant the weight gain was because of those bigger portions of. And certainly the weight loss can keep persisting, and you can lose more weight, because one of the things that was noticed in the studies that looked at weight loss after this procedure was that patients sort of relearned some of the eating habits. They also relearn what the right portion size should be, and that helps them have more sustained weight loss and, in fact, lose more weight beyond the effectiveness of this procedure, which is about for 6 months to a year.
I see. Excuse me. Now, fear, misinformation, social stigma, our patient population with morbid obesity, they deal with these on a day-to-day, every day, on a daily basis. What message would you give to a patient who's considering the surgery, but they're not 100% sure about it?
Okay. What I would tell patients is, decision about what to do for losing their extra body weight is tough. It's hard. But if they've come to a point where they realize that their weight loss is affecting their weight gain is an issue, and it's they need to talk to a doctor that is specialized in the field of helping people lose weight. So we have a team of surgeons and medical doctors who specialize in looking and taking care of patients who are suffering from excess body weight disorders, and help them lose weight in order to be successful. Surgery is one of the tools that's available. And the best people to help give the right advice to patients who are kind of not sure what path to take is to talk to people with experience in our practice. I like to boast about this, but we have 4 surgeons in our practice, and we have 2 more joining. But our combined experience, if you take all the years of experience
Right.
that we have between the 4 of us, it's like 50, 60 years of experience, right? And that kind of experience can provide so much benefit to patients. They, and we love taking care of our patients. We love to do what we do. We've been doing this for a long time, and we are passionate about our field. So if you are at a point where you're deciding, okay, if surgery is not right, listen, coming in talking to us doesn't mean you have to have surgery. It's just an introduction to what the best path forward for them would be. We might end up saying, hey, surgery is not right for you. Maybe the right thing is to have some medicine, or let's start with medicine and see how you do. If you don't lose enough weight, then maybe then you do surgery, or let's go ahead and do surgery. And I want to give an example here, and this is not new. 15 years ago, the European 15 or 12 or 15 years ago, the European Diabetes Association, they in fact suggested that gastric bypass should be the first line treatment, not second line, not third line, should be the first line treatment for treatment of diabetes in patients that suffer from obesity at the same time. So anybody with a body mass index of 35 or higher, gastric bypass, bariatric surgery should be the first line treatment. That means instead of taking metformin, have the surgery instead.
Interesting. Yep.
So that's old data. That's 12 to 15 years old. And, what that really tells us is that, these surgeries, while, surgery can be scary, but what they really do is modify your metabolic system, modify the way you digest food, modify a lot of your hormones, modify your hunger hormones. In fact, GLP-1, we talk about this so much now, but as surgeons, we've known about GLP-1, increased GLP-1 activity after gastric bypass. And we've known about this for years. The research has been on for years. So that GLP-1 effect is also happening in a gastric bypass patient.
Sure.
Yep. So there you go. So that's what I would say. Come and talk to us, or come and talk to a surgical team, or come and talk to a medical weight loss specialist team, and see what they have to offer, and go from there.
No, that's important to know. And the other thing is that you mentioned, like, surgery can sound like scary, but in our surgery center, we discharge our patients after the operation in 6 hours average. So it's different than the hospital experience. So they don't need to even stay overnight. They go home same day. I mean, that was a game changer for many of. It probably still is, because every time I talk to the hospital-based program, they're like, "What? What are you doing?" And I'm like, well, the best place for the patient, if it's the right conditions for their home. We have a way of we are equipped to keep the patient in our surgery center overnight. But if we take care of everything, and the patient can be discharged, they go home in 6 hours. So that scary part should be a little bit less. And when I get our patient surveys, and this is also available on our website, patients are extremely happy with what they see and how they are being treated, and their outcome. So this is one of the most rewarding part of maybe medicine, when you see patients who are so happy with the outcome. Well, Dr. Singh, thank you so much for your honesty and clarity today. As we discuss, while medication may have a role in mild cases or short-term support, they are not a replacement for long-term, life-altering benefits of bariatric surgery. And your healthcare providers are going to give you the best opinion on these. Please start with your primary care physicians. Come to our bariatricians, our nutritionists, come to our surgeons to get the most accurate information that you need. Our goal is to make sure that we can make an impact long term in your life, and that's why we are here for. So until next time, please stay united. We'll see you soon.